Hello. So,
Hello.
Hi.
wow. Okay, well, it's time to start, and we have an hour. And I was thinking the last 15 minutes or so would be good to maybe for questions. And I am going to start by saying, wow, what a great honor it is to be able to have introduced this great trio here for the IIPDW. I'm not going to introduce you because I'm going to let you introduce yourselves. But I know you're wanting to sort of start off on the introduce yourselves and then talk about what you do that's most effective in your work, because what you all three do is support people getting off psychiatric drugs, of course, among other things. And again, very important, people will not, we won't be able to answer personal sort of queries on, personal stories and personal withdrawal questions. But I'm sure you three will be coming in on some of the topics that will be very relevant to a large number of our audience. So without any further ado, thank you. And well, I think I'll just start with you, Angela, because you're on the top of my list up on my screen here.
Okay.
So,
Well,
yeah.
well, thank you for having me. Hello, everybody in the audience. My name is Angie Peacock. So many of you have seen the film Medicating Normal. It shows part of my story. If you haven't seen it yet, go watch it. It's medicatingnormal.com. But basically, I was medicated after a series of really horrific traumas serving in the U.S. military. I was a patient for 13 years. I was on more than 40 psychiatric drugs in a 13-year period, 18 at the same time at one point. I just listened to a voice inside of me that said, something's not right here. What is going on? I got off of everything. I went through 3 years of horrific withdrawal. It took me about 6 to get to like 80% of healing. So it was a very long journey, very severe. And then about a year ago, I've been coaching people all along, how to just get through this experience. But just recently I started doing full-time coaching and consulting for people that are coming off and leaving the system. I have a master's in social work, but I do not work in the system. So this is my passion. I think this is my life's work, just because I know how bad it is and how stigmatizing it is. So that's me.
I resonate with that, really. Yeah. Thank you. How about you, Anne?
Hi, yeah, welcome. Thank you so much for having me here to be part of this panel. It's marvelous, and I've come at this through a very, very different route. I'm a psychotherapist. I read Bob Whittaker's book, Anatomy of an Epidemic, probably about 7 or 8 years ago now, and I was just horrified. I was just horrified at the thought that I might be inadvertently compounding harm by not knowing about these drugs. So I have come into this work as a psychotherapist who wants to try and make sure that all of my colleagues know about this so that we can really try and prevent suffering. And so I was involved in editing guidance for psychological therapists on how to have conversations about taking or withdrawing from drugs, from psychiatric drugs. And as a result of doing that, I've had quite a few people start to come to me wanting support. So my clients generally fall into 3 groups. Just my normal psychotherapy clients who I end up talking to about drugs because they're taking them or they're asking me questions. And it's about that preventing suffering by giving information. Then there are those people who seek me out for withdrawal support and psychotherapy. They've got issues that they want to work through. But they also want to work with somebody who understands what they're going through. And then there are people who really just want withdrawal support. They don't really want therapy, but there's nowhere else to go for one-to-one support. So I'm working through this, as each new client turns up, working out what it is they need. How can I help? Am I best placed to help? And being honest about that. Actually, that's the biggest and most important thing is being honest about what I can offer and what my experience is, really. But that's who I am. I mean, I do have a policy hat as well. I work with the all-party parliamentary group for prescribed drug dependence. We try and influence policy in the UK, trying to make sure we actually get services introduced to help people go through this. But that's not my hat today. Today, I'm here with my kind of withdrawal informed therapist hat on. But as I say, I'm not a peer supporter in that respect.
Thank you very much. And finally, you, Will, whom I've known for many, many years.
Yes, it's wonderful to be here with you, Olga, and everyone, and Lucy behind the scenes, all the organizing. I'm really grateful and honored to be on this panel. And yeah, I guess it's been about 20 years that I've been involved with this issue. I was kidnapped and brought into the system against my will. I got a diagnosis of schizophrenia, schizoaffective disorder, schizophrenia, and it took me many years to recognize that the system was actually making my problems much worse, that was a kind of a spell that was cast on me, a self-fulfilling prophecy, and that really my difficulties in life came from trauma, and also my sensitivities, and also just having difficulty finding a place to fit in and be accepted, and to not be an outsider and disconnected. And after kind of trying to kind of get back to normal and trying to get back to my sense of what a productive individual was, that failed. So I went the other route. I got very involved with the patient survivor movement and started to really embrace my difference and really claim myself and my altered states, the voices that I hear, the visionary experiences that I have, and the different perspective that I have from a lot of people. And it was really the patient survivor movement that was able to get me off of disability, able to get me more connected. And I still struggle. I still have altered and extreme states. I still have suicidal feelings. But because of connection with other people and not being isolated, and also having a sense of empowerment and meaning for my experience, and then a lot of trial and error, I was able to get off of disability. And the support groups that we started in Western Massachusetts, one thing led to another. We started to be invited into giving talks. I started to do trainings, and then I went and got a counseling degree and evolved into what I do today, which is to work as a therapist, as well as continuing to work as a volunteer in the community psychiatric survivor, the MAD movement. And I also was invited into a PhD research program. And so my PhD research at Maastricht University is a global survey on antipsychotic drug withdrawal, including about 1,600 people who we interviewed who had a psychosis diagnosis. So I'm very interested to see how that research supports the knowledge that we've learned in the survivor movement, the knowledge that we've learned at the Icarus Project, at the Freedom Center, in the support groups that we do. And what we're seeing is that the basic framework of the harm reduction guide for coming off of psychiatric drugs that I wrote, the work that I know Angie does, and Anne and Olga do, the work of the Wildflower Alliance, the Fireweed Collective, Surviving Antidepressants, Inner Compass. Slowly, we're developing an evidence base in the research to support the idea of individualized, patient-centered, specific support on a withdrawal journey. So I'm really happy to be here and be connecting with all of you. So thanks a lot.
Well, it was really great to see you all, and I'm hoping you might be able to share a little bit. I'm sure there are people who would be really interested. Will, if you can share a little bit about what your research is showing, perhaps. I don't know
Well,
if
it's
that's a possibility. at some
yeah,
point.
I can do that. So there's a whole statistical science of analyzing survey data. So you have to kind of speak the language of the scientists. And we looked at things like how much support people had. We looked at the different the severity of the withdrawal effects. We looked at things like the severity of their crisis, like how many suicide attempts. And we looked at all these different variables. And then we gathered them into factors like support, like the severity of side effects, the length of time in the system. And we're trying to sort of think about what is the thing that most predicts successful antipsychotic withdrawal. And I can't really get so much into the final results because we're still in the process of this statistical analysis. And I'm working with an economist actually at the University of Nevada in Reno. But what we're seeing from the data is that it seems to be that the most significant factor in predicting successful antipsychotic withdrawal is having support that's not just support, but that's very responsive, that's very flexible, that's able to change course, that's very tailored to the individual. It doesn't create an algorithm that says one thing is better than the other, but rather works with the individual's specific needs. Now, this is something that everyone here on the panel has learned through experience. So it's very exciting to see this confirmed from a scientific evidence-based methodology.
Yeah, very, very interesting. And I'm thinking, I don't know about you, Angie, and Anne, but I was thinking also if any of it is showing some of the results regarding actual withdrawal, because I certainly have found it to be very individual and very, very different. In other words, this whole, standardized attempt at standardizing withdrawal is an interesting, perhaps, a question. So, but I'd love to hear how you work with people and perhaps share and what inspires you and what's most effective in your work. Maybe you can
Should I go
start
first?
Yeah, Angie. Yeah,
I'll start. Okay,
Yeah.
so I think I work with like 6 categories of people. People that just figure out, my drugs are causing me a problem. I'm not sure what to do about that. People that are in the tapering process, they've figured it out. They found the online communities. People that are in cold turkey withdrawal that usually figure it out later. They didn't know. They get cold turkeyed by a doctor or something happens. Then there's people that are, I would say like 18 months off to 5 or 6 years off, and they're still suffering from pretty severe symptoms. Then there's another set of people that are, I'm getting my life back. This is really hard. I'm not sure how to do this. How did you do this, Angie? Is this still normal at 6 years out? Like, I can't believe I still have symptoms at 6 years out. And then mad pride perspective, like people looking for just like, kind of like what Will was saying, like, I don't look at my experience through the lens of a medical model. I know I'm different. It's okay. And like, how do I live in this world when you know so much, And then the last set of people is families. I don't know why, but families flock to me, and it's usually their child or a grown adult. They've been in the system. They have a severe mental illness, like schizophrenia or whatever that means, and schizoaffective and psychosis. They have all these diagnoses. The system has basically dropped them off, and they say, we don't know what to do. We've tried all the meds. We tried all the hospitalizations. What do we do now? Like, we don't know what to do. So those are the people I work with. It's like a huge span. And kind of like Will, I feel like I've been very boots on the ground this last year, and I feel like I'm running a marathon kind of, but I've seen about 1,000 cases in 1 year. And I've heard, I'm still like shocked at like how bad the system can treat people like us. And how there's little support. You do start to recognize patterns, like things that make people more successful. It's always changing course. Like, you can have a plan, but it can change at any time. It's also very like uncertain. We don't know. Nobody knows. We don't even know what's going on and why your body has changed the way it has, or even what to do about it. And it's a day by day, minute by minute. Like, just please hang in there. Don't hurt yourself. You're going to make it. The body is resilient. You will heal. I mean, that's for certain. I always say I would never do this work if I just watched people suffering all day. We do heal. We are resilient. The body is just a little bit stronger than the psychiatric drugs, thank God. So that's kind of what I do. That's what inspires me, is just, I mean, the people I sit with every day, I just feel so much love, like just sensitive people that have been treated really poorly and they fight for their lives and it should have never happened. But they do heal in the end. So that's me.
Thank you. So yeah, wow, 1,000 people a year. That's quite a lot. What about you, Anne? How?
Yeah, I'm not going to sort of, I'm going to try and sort of speak to something that's, I think is a bit different in my experience of being kind of being a psychotherapist in normal private practice, if you like, and how to navigate dealing with psychiatric drugs in practice. And the importance, do you know what, the overriding thing, and I think trying to get this through in the guidance and through any kind of talk that I do, is how important it is to let the client be the guide as to what they're experiencing, to validate that, and whether it's to do with withdrawal or whether it's actually part of who they were before. And that is so important to keep checking in about, is this new? Is this post-withdrawal? Is this part of your experience with the drugs? And keep orientating back to that so that you can understand where the person starts and stops and where the drugs start and stop. And of course, you know, so many people have had such traumatic times with this that it becomes interwoven in their story. And as you were saying, Angie, working out who they are once they end this journey, that's another whole, you know, topic. And it's being so open to the client's understanding of what's happened to them. And I mean, to be honest, this is meat and drink for normal therapy anyway. It should be. But it can be really hard at times to work out where the boundaries are. So if, for example, you've got somebody who's had a really strong health anxiety their entire life, who is now going through this, boy, can that be hard for them and for you to work out what's proportionate to what they're going through and what may be about an earlier story, and where did that earlier health anxiety come from? Now, clearly, when somebody's in the midst of withdrawal, you're not necessarily going to do that deep work because that's not the time to do it. But it's holding open this possibility of exploring at some point how who you are has played into your experience of and dealings with the system, with psychiatric drugs, with doctors. What relationships have you been left with? How are you able to trust doctors again? And I think it's so difficult when I see people who have been harmed, or I've read people's experiences who've been so harmed by drugs, they lose all faith in the entire medical profession completely. And of course, there are times when, sadly, we're all going to need doctors for, you know, non-distress related issues, and that can be really hard to. How do you begin to trust again that a doctor knows what they're talking about, without feeling like you've got to go and train yourself and become an expert in anything that you've got in order to interpret what you're being advised. So there's a whole passel of issues in what I've just said. I appreciate that, but it's this working out these boundaries, where they apply, where they don't apply, what's helpful, what's not helpful. When is somebody avoiding something in a therapeutic sense, or when are they actually in a stage where they just can't deal with it? Always you have to be guided by them, but it's this very delicate line that you're always trying to tread in understanding this intersection between the experience of psychiatric drugs and personal experience. And of course, it's all personal experience, and that's what's so hard. I remember many of you, I'm sure, know Baylissa Frederick, and I remember how adamant she was or has been with me about, look, if in doubt, the first assumption always is that this is about the drugs. And I absolutely retain that as my mantra. And I will say that to clients, that that's where we'll start. That will be our assumption, because the last thing I want to do is psychologize something which is a physiological response. But actually working that out in real life with real life clients who've got previous issues of emotional distress that they do want to talk to me about, that's the work. That's what keeps me inspired and passionate about this and curious. And how on earth to train other psychological therapists in this subject.
Yes, I was just thinking I've had to use a doctor here this last year, and you know, for illness things rather than psychiatry, and the service has been mind-blowing in its difference, being met politely and informed. I mean, oh my goodness, I didn't know it was possible. Well, how about you? Can you maybe share some of your ways of working with people, helping them through their struggles?
Yeah, well, I just want to comment on that. I think that people definitely have many experiences in let's call the non-psychiatric healthcare system that are horrible and atrocious as well. And it's a question of whether patient-centered care and collaboration rather than authoritarianism is taking place. But what you said, Olga, reminds me of my mother had a stroke about a year ago, and she's doing great. She's really doing really well with it. But the contrast of how the response was compared to a psychiatric response, the common sense and the time and the listening and the responsiveness and the tailoring of an approach to her, and the number of services and the lack of coercion and the entire collaborative atmosphere was so different to me in that context. So I think psychiatry is really kind of lagging behind this movement to have collaboration and be patient-centered. But basically, I mean, I think the real core issue is, for me, fear. It's fundamentally what people are going through. And there's this, of course, this natural grasping for control and for certainty when we're facing something as overwhelming and as life-threatening as what we're talking about. And yet the reality is that we cannot give them certainty. We can't even give ourselves certainty, nor can we give people a sense of control about what is the right thing to do. And that this is absolutely supported by the research. It's also something that's supported by addiction research. There is no particular specific protocol or algorithm or specific path for addiction treatment, because the experience is so individual. So to help people with fear and to help people encounter making decisions when they can't control or be certain, you have to have a deeply personal, connected, trusting relationship. So that's the first thing I do. I lean on my own personal experience. Someone can say, I don't trust doctors. I can say, well, yeah, I don't trust doctors too. I don't trust diagnosis. Well, yeah, here I have the same experience I went through. And so when I say I'm not going to force someone into the hospital, when I say I'm not going to interpret, I even will tell people, your mom says that you want to work on coming off of psychiatric meds, but now I'm sitting down with you. What do you want to talk about? Maybe you want to talk about some of your mom's problems or your father's problems. I mean, I'm very oriented around the client being the leader and the boss and the center. And so I have to be willing to face that I don't know, not because I'm not a pharmacologist or I'm not a psychiatrist, but because nobody knows. Nobody knows. Nobody knows. And so I cannot give advice because I not because I'm against giving advice. If I had the perfect advice and the certain advice, I would certainly give it. But I can't give advice because I can't predict or guarantee. So I'm very honest about that. And at the same time, as I help someone go through that, which I hope will ignite their own trust in their intuition, because the body, your thinking has a certain intelligence, but your body and your heart and your physiology and your organs, they know there's a general kind of intuitive gut sense of, well, I think I maybe should start with this drug, or wow, maybe we should slow down on the taper, and creating a space where that deeper wisdom can come through, because ultimately we're all trying to move forward in the dark. And of course, comparing the pros and cons and past experience, what happened the last time you tried this is very important. But as I'm helping people to encounter the feelings of being out of control and the sense of I can't predict, I also have 100% unshakable confidence that this person can get better. I absolutely, because I don't know what it's going to look like. It may be they don't come off of their meds, but I do know that they can get better. And I believe that I know that I've helped them. And if I can't help this person, I will help them find someone that can. And they can feel that confidence, that belief, that faith in them that we all have. I love, Angie, what you said, that our bodies are thankfully more powerful than these drugs. Our wisdom is wiser than these drugs. So that means facing the fears of suicide. That's one of the kind of the biggest. And so I lean on the fact that we don't know, we can't predict who is going to kill themselves, who is not going to kill themselves. The suicidology, psychiatry, there are no answers to what causes one person facing extreme pain and hopelessness to end their life and another person to not end their life. So I have to encounter that in my own fears of like, oh, if I do the wrong thing, is this person going to end up? Of course, I have to try and do the best I can and always learn, but I cannot predict the suicidal feelings. I can't predict hospitals, violence. I can't predict the worsening of crisis, all these things that I would be afraid of. And of course, one of the biggest fears is like, well, what if someone sues me? What if someone gets hurt and then there's a lawsuit? And I did some research on this, and you would think, and I'll just kind of wrap it up, but you would think that doctors or professionals or individuals in the kind of a supportive role would get sued when someone gets hurt, there's a mistake, and it goes against the standard of care. When you have an injury, a mistake, and going against the standard of care, then you have the ingredients for a lawsuit. Actually, that's not true. What leads to lawsuits in this realm is not when there's a mistake, the standard of care is violated and someone gets hurt. What leads to lawsuits is when there's a breakdown in the relationship between the provider. So I emphasize over and over again to myself that I'm constantly working on connecting, building that trust. I work with a young person, for example, I'm meeting with them, I'm helping them, it's their decision, I'm following. Here comes the father, sends me an email. Why are you telling my son to come off meds? Well, that's of course not what I'm doing. But my response is not to just delete the email or write an email back saying, how dare you accuse me of doing something I'm not, but saying, thank you for getting involved with this. I want you to be involved. I care about and to build that relationship. And then I find that that will help me feel like I've done the best that I can. Because really, if you're encountering people in distress and in crisis and who are facing life-threatening decisions, there's always going to be that fear that something difficult or bad is going to happen. But if I can confront that fear honestly and do the best that I can, and then let go, it's like the serenity prayer, God, give me the clarity to help with the things I can help with, to let go of the things that I can't, and to know the difference. So much wisdom has come out of the 12-step and the addiction recovery world around. I'm often leaning on, I guess it's Al-Anon, the parents and family members of someone who has an addiction. It's the same kind of wisdom has come through. Like, how do we support people without having to control them, without having to give them, our own emotional baggage to unload on them, to let them make mistakes, support them to go through their own learning process. So I'll just wrap it up with that. But those are some basic things that I come at this work from.
Oh, it's very, very important, very, very, because there's also, it's not just the fear of, people who are withdrawing, their own fears, but it can also be fears from, embarking on helping, especially the way, it's such a new field, and makes me also again want to ask, we've as survivors, we've known about withdrawal for years and years, and there's a vast amount of knowledge available. interesting discussion is also what is our role there, you know, in the now, because it's suddenly been become very interesting for the medical field, and which is of course really important and great. And another thought I was thinking was also for people who've tried to get off for an awfully long time. There are people who have been damaged by the drugs, and they you know, so what's your experiences in supporting people, you know, with protracted withdrawal, you know, people who've been so damaged by the drugs? Yeah, so many thoughts. Yeah, so both
Well,
the
I want to
political and
piggyback off.
yeah,
I want to piggyback
yeah,
off something Will said, because this is what
Mhm.
I find so it's so different from like modern day
Mhm.
therapy or social work or whatever.
Mhm.
Like often I just find kind of what Will was saying, like the
Mhm.
person needs help making a decision. They need to hear themselves talk. Like, okay,
Mhm.
I'm on Effexor, gabapentin, Wellbutrin. Okay, what are the pros and cons of each choice?
Yeah.
You know, what is the taper rate? What does that look like? What's your
Mm.
support? But I don't know the answers. I'm just asking them questions so they can hear themselves and work that out for
Mm.
themselves. And I think it's opposite,
Exactly.
because in the, you know, working normal therapy or social work, for me, it was more like I know what's best and I'm working through this lens and I'm thinking of things while
Mm.
the person's talking. So this experience for a lot of people, it's kind of disheartening when you figure out there's no magic pill to take away withdrawal. There's no doctor, there's no program, there's really no book, there's no protocol, there's no algorithm. Like I have to, like, whether I want to or not, I'm really honest about this too. Like, and it sounds harsh, I think, but my experience was that it was me and my suffering in a room.
Mm.
And there was no way out. And it was like very much like I'm in the corner and there's no drug to take and there's no money to buy me out of this situation, or there's no, and for
Mm.
that, it's the hardest. I mean, to me, it's like inhumane almost,
Mm.
because it's so brutal for so many of us.
Mm.
And so I think on the protracted question, I just started a protracted support group. It's only been going 3 months, and it's invite only because I have to make sure everybody's like on the same,
Mm.
you know, in the
Page,
same
yeah.
trajectory or everything. But
Mm.
protracted is the most misunderstood of all, because everyone is afraid of us. Like,
Mm.
how could you possibly have symptoms for 6 years? And I'm
Mm.
like, we do. I'm living it.
Mm.
I'm here. I'm 7 years off. I still have visual and vestibular disturbances and, you know, extreme states sometimes, and things that I know that if I told anybody, I would meet criteria for something, you know, but
Mm.
I'm just different with that experience. So yeah, this experience is just, I always say, like, it's like dropping an atom bomb in your life. Like everything you think about, everything gets rethought, and you can build a good life out of that rubble, but it's
Mm.
extremely hard, and nobody invites this on themselves. We don't want it. And it was even our sincere hope to heal that we got in the system in the first place. Like, I want help. I want to feel better. Something's
Mm.
not right.
Mm.
And then you're kind of like up against a wall by yourself at the end. So,
Mm.
and you get abandoned by the medical system on top of it, which is more trauma. Yeah.
Mm.
I just want to say I just really struck, like, listening to you, Angie, like, it's just so powerful for me. I mean, your wisdom is not just wisdom about coming off of meds and helping people with withdrawal. Because of your suffering, you've gained just life wisdom as a human being in encountering the mystery and the suffering and the life struggles and I think that's that's the beauty of working with people who are suffering so much, and working with your own suffering, is that
Yeah.
knowledge and that wisdom and that strength comes through. And I really hear that when I
Thank you.
sit with
Yeah.
other survivors and other people who are
Mhm.
working on this.
Yeah,
So
it's always like when people ask me, like, what do you do? I'm always like, I don't know how to answer that, because I want to say, like, I'm a healing coach or something. And I'm like, I don't heal anybody. And then I'm like, am I a suffering coach? Like, I'm helping people how to suffer, because like
right.
we're suffering. Like, I don't know what else to call it. We're suffering and we're in
Yeah.
this, and how are we going to suffer and like make it
Yeah.
out? You know,
You're
it's so
human.
hard. Like, what is
You-
it that we do? I don't even know what we do.
You're a human collaborator. I mean, I often am coming up. I'm often coming up at this moment, and I often am recommending, if people like it, maybe they don't. Again, I don't know whether they're going to find this useful. But Viktor Frankl's book,
Yes.
Man in
Yes.
Search of Meaning. Like, what do you do if you are trapped? There's no way out, and you're just suffering, and everything looks like bad option, and you have no power. Like, what do you do? Yeah, what an incredible
Just
conversation
suffer.
to
Yeah.
have with people. I'm so honored to have that, to be with someone at the depths of hell. In a way, it's this incredibly spiritual, deeply honoring human experience. I feel so grateful and so fortunate to do this work. even as I get scared, and even as I'm like,
Yes.
whoa, how do I help this? What do I do? I'm overwhelmed. Or what if I said the wrong thing, or I haven't heard from this person, or what, so.
I think you're right. Sometimes we're just a witness, to be there alongside somebody who is suffering, real depths. And I'm conscious that, I'm not coming at this from a personal experience point of view, but you can still hear somebody else's experience, even if it's not yours. And I think sometimes the power of somebody who hasn't been through it, hearing it and listening to it, and responding empathetically, can be huge from what I hear people say. And I'm also conscious of all the voices who don't have a chance to express themselves, even because maybe they got put back on the drugs, maybe they tried taking themselves off and thought, oh, my problems come back, and put themselves back on the drugs. If we consider 25% of our population is currently taking these drugs, this vast cohort of people who are standing potentially on the edge of this cliff and have no clue. I think, that's partly what motivates me for all of the campaigning work, if you like, in terms of the awareness raising and services and educating to stop people having to go where you guys have had to go. It's, there's so many different groups here, and there's a big silent group, and all of those people who've been through it and didn't know what they went through. I was wondering earlier how many thousands and thousands of people there will be who went through it and didn't know.
That's a huge tragedy. Those, many people. Yes, and 25%. Wow, it's so many people. I was thinking about this this knowledge we were talking earlier, or in the meeting earlier, about coming it from a peer perspective or a non-medical perspective. The knowledge that's gathered there, should it become a medical speciality of only trained doctors allowed to help people withdraw? Should it be, do you think there's a role for us? Should the medical system become active in this?
We're having a lot of conversations in the UK about deprescribing and the role. It's kind of the medical system created this problem, and that they have a role to play. If they put people on drugs, they should know how to take them safely off the drugs, and actually starting deprescribing clinics. And of course, Mark Horowitz has started one in London in the UK.
Yes.
So I think there is a duty, there's a responsibility on doctors to get this, to understand it. Whether they are capable or have the resources to offer what people need, that's a different matter. But I appreciate that for some people, and when we were talking earlier about those who don't want to be treated by the system because they've been so harmed by it, this is the debate about, do these services sit inside the system or outside? And I think it needs to be both, because different groups have different needs.
Yeah, me and Ann talked about this about a month ago on a call about, like, a lot of people that I see, they don't want anything to do with the system. They don't want any notes taken, and we talked about fear. Will keeps hitting on it because we wanted to get to this subject also, but there's like this fear, like, just me as a person, I'm like, am I technically a mandated reporter? And I don't want to be, because like I work with deeply suicidal people. I mean, I had one last night, and it's like, I go to sleep sometimes and I'm like, I'm not sure if they're going to make it, but I cannot, in my own ethics of what I've experienced, someone who is that suicidal, call 911 on them, where I know what's going to happen. They will get put back on meds. They will be forcibly medicated and put in a hospital. I can't participate in that. So there's fear for me. Like, I'm putting my life on the line for the people that I'm helping. I don't want to work in the system. I don't want to take notes. I don't want nothing to do with that. And my clients don't either. And this is very controversial, what I'm about to say, and I'm scared to say it, but I'm going to say it. But that, like, I tell people, like, I'm very comfortable in the dark. I'm very comfortable with all of the suicidal, homicidal. I had it so bad for so many years and I had no one to talk to about it. So I do think there's a spectrum of people, some that are looking for, you know, even just monetary, like, I have to be paid for my my services. Otherwise I could just work in the system and get paid that way. But so people want to use their insurance. I can't take insurance if I'm going to not participate in the system, you know, so there's all these other issues that go there too. But so yeah, I think there's patients all over the place, or people all over the place, that some want to work in the system, want to talk to a mental health professional, want therapy. That's not where I'm here for, you know. I'm different in that way. Yeah.
Well,
No,
even
and
if
sorry, beg your pardon. Well, please
I
carry
was just going to say that even if there's a kind of reflexive, I need to go to the doctor to get this solved. That's the expert that has the knowledge. And the first thing that expert needs to do, that doctor needs to do in order to be ethical, is to say, wait a second, I'm not fixing the car here. I'm not an auto mechanic. This is not like other, treatments for other, it's not about setting a bone. I don't have the answers. And society has given me the power to lock you up and assault you, kidnap you, bully you, torture you, if you say certain things to me. And I have our doctors, our medical professionals going to actually protect their clients and patients from the harm of the system. Are they going to be honest about what they know and don't know? No, they're probably not, unless we have larger change. I mean, a lot of times people have an approach which is like, well, I need to go to a clinic so that I can withdraw. And it's sort of the idea, okay, I'm on these drugs, I'm on heroin, I'm addicted to cocaine, I have to go to a rehab detox center. The research shows that rehab detox centers don't even work for addiction. That's not actually how for some people, maybe, but the idea that you're just going to flush it out of your system and then you're done, that's a kind of like a media-driven stereotype misunderstanding. But there's a huge market. All those centers are trying to get patients to come in and do these rapid detoxes in the rehab centers. Doctors are going to start seeing this as a market. They're going to see it as another realm that they can exert their power and be the experts and do the billing. And so I think that one of the things that's compelling about this issue of iatrogenic drug harm and the way in which people are prescribed and then have much, much worse problems is that it illuminates how the system as a whole is broken. Our entire healthcare system is in crisis. I don't fundamentally think we can solve the psychiatric drug and withdrawal issue in private for-profit healthcare. I don't think we can solve the issue of emotional distress unless we break the stranglehold of experts saying that it's not communities that take care of each other, it's going to the experts that take care of each other. And that means large-scale social change, but those are the conversations that need to happen, because the reality is, I've been doing this work for 20 years. Everything is worse now. I'm really glad the Hearing Voices movement is growing. I helped that. I'm really glad and proud of helping Open Dialogue grow. I'm really proud of all the changes that have happened. The whole thing's getting worse. I don't want to be on a panel in 10 years with all of you saying the same thing, dealing with the same problem, except now it's 60% of the population is on psychiatric drugs and Frankenstein psychedelics and all this kind of weird stuff. We got to really deal with the fundamental issue, which is that people don't have the time and the confidence and the space to really take care of each other in our society.
It makes me think of, trying to save people floating by, drowning in the river, and we're trying to save all these people instead of going further up the river and figuring out how do we stop them, falling into the river and drowning.
Then I always think, like, what's it going to take? Because if you go on psych Twitter, the Twitter, which is traumatizing, just reading some of the tweets. But, I've had clients say, Angie, if you ever hear a doctor and they want to come listen, let them come listen. And I'm like, come sit with me for a day and you will see. It's right here. I don't, it's, they, a lot of them claim withdrawal doesn't exist. My own doctor did that. That doesn't know you have MS. That's not withdrawal. It's in your head. okay, well, come sit with me, Will or Ann, and you can hear it. It's right here. We have the, you know, so I always feel like the cognitive dissonance is so strong. You know, I don't know how to fight that. So where's my power right now? My power right now is just helping one-on-one. It's hard, you know,
Well,
but
we need a movement. We need this. It all comes back to the patient survivor movement. I mean, Dr. Caligari's psychiatric drugs. People have been doing this in the underground. Our bodies ourselves from the women's movement. I mean, that's fundamentally what it comes back to. And I think that the way movements come from testimony, movements come from people speaking their truth. So I think part of the process that is very powerful is when someone starts to get empowered and they start to come off of the meds and they start to make big changes in their life. Can they tell their stories? Because storytelling and being witnessed and being seen, that's where movements really get their strength. And that's where we can build our power. Because I think we have common sense on our side. I don't think 25% of the people are taking psychiatric drugs because they want to. They feel desperate. They feel like they don't have choices. They feel like they don't have options. They've been fed certain misinformation, but actually common sense is on our side. But ultimately, we're facing this question of power, political power, which is why I keep coming back to my roots in the psychiatric survivor movement, because it always saw itself as a movement allied with other movements for change. I can't tell you how many times I've been in a situation working with someone around withdrawal, and what comes up is an issue of poverty, an issue of homelessness, an issue of domestic violence, an issue of just, you know, how much money they have, the wages that people are getting. If we had more people in society that didn't have to work full time or 60 hours a week, if people had spare bedrooms, if people could afford to get apartments or it would open up so much space for us to create this caring. But we live in such a brutally predatory, competitive, materialist society, and it's just getting worse. Speaking about the United States primarily, but I think this is a global problem, that the options for people, and so often we're navigating the lack of resources, the lack of options.
I'm going to. It's just so that we can get some of the questions in. We have just under 15 minutes. I hope it's okay. Sorry for interrupting you.
No, please.
One of the sort of very short questions is, do you guys do online help? Just yes and no's.
Yeah, I do online, and I show up in person in a van if you need me in person. Sometimes because I travel.
Time differences permitting. Yes.
And there's some people asking about protracted withdrawal, and if it's just the professionals and people who've successfully withdrawn who can tell their stories, or can people still stuck in the labyrinth relate
everyone
experiences?
has,
I think
everyone.
Somebody was asking also, you will, regarding an economist, working with the research with the economist. Is it because of the costs of taking and withdrawing medication that
it's because
involved
of
in economist?
Statistical analysis of survey data. Also, economists are often much more concerned about choice and motivation and goals, whereas psychiatry in the psychiatric realm is often the disease model, which if you think about it, it's not really understanding patient preference or choice. It's just about treating a disease. So, but also Rachel Flanagan is the person I'm collaborating with. She's also a facilitator in the Hearing Voices movement.
Then there's a question actually to you, Anne. How do you stand with regards to people in extremes that, you know, wanting to commit suicide or something like that, or talking about it? How do you feel?
I think the regulations are different in the UK as to you know, in the US. I know if you're licensed in many states in the US, you are required to actually call help, and it's different in the UK. There is always a discussion about confidentiality with any client that I have, and we always talk about if you're at risk, we will always talk about what might be helpful to do about that, whether it's going to be useful to involve anybody else or not. And it's always a discussion, it's always individual. My first training in therapy, I worked on a suicide hotline for 3 years as a volunteer, and that was completely anonymous, so you could not actually call help for somebody because you didn't know who they were. You didn't know that what they were telling you was necessarily the truth, but it was just part of the deal that actually you're just there to be with somebody and to abide by their wishes. So it's not straightforward, and it is very, very individual. But I kind of lean more towards Angie's position that actually I did some of my training in a GP surgery, and I remember referring somebody into a GP because I thought their risk was increasing or something, you know, when I was very early trainee. And what did I think that GP was going to do? That GP could do no more, and actually they could do worse things than what I was already doing with that client. So actually, when somebody's with you, if they're talking about their feelings and you can offer them maybe additional sessions if that's what you can do, then actually that may be the best thing that you can do for somebody, and just be with them and to tolerate being able to hear it, because a lot of people close down those discussions because they can't tolerate hearing those feelings.
Yeah, to answer the question, I think we need to be very clear that we need to abolish forced treatment. We need to abolish forced treatment. It has no research-based support, and it's clearly harming so many people and makes it so we just need to be very clear and draw that line. So I really appreciate your response, Anne, to that.
Well, and we know it's actually, I don't know the word because I can't think right now, but it teaches people not to talk about their suicidal feelings because they know their rights will be taken away. So they're not going to tell you anything. So what's the point?
It's ludicrous.
Which is barking, given that, you know.
And they need a place. We need
a place to be able to share.
Where are we going to talk about it? There's nowhere else to talk about it.
That's British for barking
Very English,
mad.
right?
Barking mad, right?
Yeah.
Barking mad. It is barking mad.
I don't know about you three, but I'm thinking that when there is no, system that you can sort of push the fear onto, it opens, actually, I don't know, I find it opens doors, because when there is no alternative, there is nobody, I'm not going to call the emergency services or anything, then suddenly another door opens, I find. So true. A very profound.
So much about therapy is about death anyway. And, having open and frank discussions about what people think about death and what they feel about it and their experience of loss, that's all part of what we're there for, isn't it? To be able to be there with, Angie, when you say that phrase, which I, really resonated with, you're open to the darkness, you're aware of it, you've been there, you can be with it, you can hold it,
And as the most recent graduate from a social work program, I will tell you, they're teaching the absolute opposite of that. It's the second someone says suicide, elevate their care. Even in my training, everybody in my clinical supervision, all the students, they were like, what do we do if somebody says they were suicidal? And then it was immediately like, you come to your supervisor. And I was like, hold on a second, wait, let them talk. Why can't they talk and tell you their story? But you have to open the door, leave the room, and go tell somebody. Like, this is opposite.
When I hear that, I just ask for the research, because the research doesn't support.
That's what they're teaching.
No, and I think it's, as you were mentioning earlier, Will, fear. And fear is many things, but it's absolutely entrenched in the system. There's such a great fear for people like us as well.
We keep coming back to love is the answer. I don't know where I heard that.
Love and fear.
Love is the antidote. Love is the answer.
Yes. There's a mother saying, it's easy to say, I'm not calling 911 on you when you're away from the person. I'm thinking that I too, I don't know about you, but if family, being actually involved in the family, it's a different thing. Not a therapist, but I don't know.
It has been with my friends. It's been intimate and personal in my life. And so I understand it's very difficult, no matter who it is. Therapists and helpers, we do have a privilege of not being with the person 24/7, but we also have disadvantage of many, 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 many people, not just
Yes.
one phase of one person's life in our family. So it's a difficult spot. I wish we need more peer respites. We need more sanctuaries, soteria houses. We need places for people to go.
Caregiver support.
Yeah. Even just renting a hotel room for a few nights or something. It's a place to have a break.
Or even people losing, like they can't afford help when they are coming off of withdrawal, you know, and I know people that have lived in tents, that have lived in their cars because they lose everything. And it's doctor induced, medical system induced, you know?
Yeah. It's lots of people saying their stories here. Here's one with introduced to the healthcare in a dramatic way. Cancer.
Will the chat be saved?
Sorry.
Is the chat going to be saved so people can read the chat?
I hope so. Oh yes, it will be.
Good.
We have a little bit. Is the Maastricht survey still going on, and will it be published soon? Is a question.
Yes, antipsychotic withdrawal survey.com, and I did some reports on it, and yeah, we should be able to get the results out soon. We're hoping. A lot more work than I realized.
Do you have a timeline? A sort of
ASAP, Olga.
Okay. And here's a Korean psychiatrist asking for agrees with everything that you are saying, and is asking for advice. How can a psychiatrist help a psychiatric survivor best?
Start the movement in Korea. Get active in the movement in Korea.
Teach your colleagues about us.
Yes.
You know, they will listen to a doctor more than they will listen to me.
Translate the guidance for psychological therapists into your language and promote it amongst your colleagues.
Yeah, the harm reduction guide to coming off psychiatric drugs is in Korean, so we need more translation and
or medicating normal. We could do Korean too.
Great idea.
Yeah, absolutely.
Do a screening.
Yes,
I was stationed in South Korea. I would come for that. That would be great.
And also the marks and the video yesterday that we saw, you were watching, that can also be translated. But somebody says the chat will not be saved, sadly.
Just as a quick note of small note of optimism. I appreciate, you know, UK is in a very different place to the US, but we now understand that a commissioning framework saying that all NHS areas should set up services to support people going through prescribed drug dependence is due to be issued next month.
Oh, wow.
Now, there's no money behind it, but it's about stitching together meager resources is the phrase. And we are starting to talk to clinicians and pharmacists and psychiatrists and GPs who are interested, and we are connecting people, we're linking people up. So there will be a mandate for the NHS in the UK to set up services to support people. It's going to take time, and it's going to take a long time, but at least there is that official recognition of the problem and what people need.
And that includes all the classes of drugs, not just the addictive stimulants and benzodiazepines?
It doesn't include antipsychotics yet, but it does include antidepressants, as well as benzodiazepines, Z drugs, opioids, prescribed opioids as well.
It's an interesting one. We don't have time to discuss it, but I do think that the antipsychotics are very much on the back burner. The focus is so much on antidepressants, and I wonder why.
Well, there is. I got a graph of all the Facebook groups and how many members and their growth over the last year, and you'd be surprised. The antipsychotic peer support groups on Facebook have grown exponentially just the last year.
Yes.
So it's coming, like people are starting to figure it out. But when I read the groups, I get really scared because there's a lot of really bad advice, like, you know, go off of it, use a benzo to cover up the withdrawal. You'll be fine. I'm like, no, wait. So yeah,
Yeah.
antipsychotics, it's tricky. It's so tricky, and there's a lot of
I think they get put in the too difficult box because people are scared of psychosis. That people are, there's so much mythology and
well, the short answer
around psychosis.
The short answer is way more people are prescribed antidepressants than antipsychotics, but we are seeing antipsychotics being marketed for so-called treatment-resistant depression and sleep issues, and but I think and I think there is more fear around it, and there's also it's a less empowered group of people. It's people who are more pushed aside than any other group of people, and there is much more of a biological deterministic, you must be on this drug for the rest of your life kind of framing of it. And so this is one of the reasons that I chose to focus on antipsychotics. And
you're right. I think the penalties for speaking up are much more, real for that group of people. Anyway,
I'm afraid that's our time is up. But I think we're going to keep the chat going for at least another 15 minutes, so we can participate in that. But I just want to say on behalf of the IIPDW, you can keep in contact with us at info@iipdw.org. And we're also a non-profit, so any donations would be, of course, make a huge difference for us. And I think the link will probably pop it or be somewhere in the chat. And afterwards, when this is over and you leave, or whatever it is, click leave Zoom, you're going to be taken to a little anonymous survey to ask what you thought of our conference. So hopefully you'll be able to fill that out for us. Otherwise, I want to say thank you to the three of you. I would love to have carried on this conversation, certainly from there's such richness there. So thank you so much for sharing your knowledge and experience and philosophies, really, also on this really important topic. Thank you so much.
Thanks, Olga, and thanks, Lucy, for all your help and support.
Yeah, thanks.
So Lucy,
everybody.
I'm not quite sure. Does everyone able to come join,
There she is.
or how's it? Oh, there you are, Lucy. Yeah,
Thanks,
great.
Lucy.
Thank you.
Thank you.
Yeah.
To see you.
I've learned so much, and not just about Zoom.
Mm.
Yeah, it's been an honor.
Yeah. Is the chat up? No, or is it open? Can all faces turn up, or how's that work?
So I'm going to leave the chat open for 15 minutes.
Okay.
And the chat can't be saved, just so that people feel comfortable to share their experiences. But I will save all the links that you share, and I'll send them around. Okay. But
Great. Yes.
apart from that, I'll put you back in the audience so you can join in the chat if you want.
Thank you.
Thanks, everybody.
Thank
Bye.
you.
everybody.
Nice to
Thank
be
you.
with you.
Bye-bye.
Bye.
Thank you, and thank you to the three of you.
Thanks, everyone.